Hello viewers, today again I am back here with a very interesting case, I always say, but this time I am not only the interest but what is important for you in the practical exam is that how you need to discuss. The case may be uncommon but your approach to the examination is more important when you appear for the examination. This was a child who got admitted here at BSC hospital on the 16th of April. He's a 12-year-old male child, got admitted with a history of fever 15 days ago for only 2 days. The child got admitted with the complaints of this fever, which was there earlier, pain abdomen and vomiting for about 4 days. When the child came, the child was looking very pale, and as soon as the child passed the urine, it was red colored. Then we approached the father and asked them, but they never complained of that this child has been having high colored or red colored urine. But then he said that this child has been having blood in the high colored urine for the last about 4 days. So keeping all things in mind, then as I always say, important histories we took it. The important histories were, there was no history of any, you see, there was no history the child was having any rash or any bleeding into the skin. That history was not there. Now, one important history which was very important, I will go into the negative history, but let me complete the first positive history. The one important history which I missed was that this child was playing in the contaminated pool where the kettles are kept. So that was very important history. The child takes bath there. Well, then going into the negative history, what negative histories I asked was that there was no loose motions, there was no blood in the stools, there were no joint pains, no arthritis. As I said earlier, there was no history of any bleeding into the skin or into the subcutaneous tissue. No history of any alteration in sensorium, no history of any seizures, and at that time there was no history of any prolonged drug intake. Keeping those things in mind, we went on to the past history. Past history was absolutely all right. The child had been keeping well. So this is all in the history. Now, when I was taking the history, as I said, we also noticed the child got admitted because the child was very pale. The child had been with us for a few days, and during the indoors, child never had any fever. So that means during the indoors, the child was not having, the child was afebrile. Now when I examined this child was very pale. So it was a pale child, anictric, afebrile as I said, and there were no petechiae, and you will see the video. Hello, now I am showing you the video for the child which I am talking about. See, this child is quite looking pale. Length of the child or the height of the child is okay. And now I am trying to show you that there is no bleeding into the skin, at least in the extremities. So there was no bleeding purpura in any of the body or in the limbs. See, the child is looking very pale. I am trying to focus the tongue. See the hands, and they are very pale. So child was very pale, looking very pale. And now on the top of it, if you could see the urine, it is high colored. So it is hematuria is there. So and here I have tried to focus the child's parts, that I could not find any petechiae or purpura. The pulse rate of the child was about 98. As I said, child was afebrile, and respiratory rate was about 20. So respiratory rate was normal. Now regarding the weight of the BP was very important, yes, and since it was a 12-year-old child, on repeated occasions we did the BP, and BP of the child was 110/70. So for that limit, the child was having normal blood pressure for that age. It's a 12-year-old baby. The weight of the child was about 23 kgs, expected about 34. So child was little slim, you can say, or little cachexic. But the height of the child is okay, about 134 centimeters. As I earlier said, and on examination also we asked the child to collect the urine in the bottle. So when we saw that urine, it was high colored or red colored urine. So those things, but the child was not oliguric. That is very important. The urinary output was about 1.5 ml per kg per hour. So keeping all those things in mind, I have given you the general physical examination, which I did. Systemic examination of this child was all right. Now, this is, I always stress on my channel that based on this history, I have done the general physical examination as well as systemic. Now, now let me ask the questions to my postgraduates or to my residents. What possibilities would you like to keep? Pankaj, you would like to say anything?
So, as child presented with fever and hematuria, common things can be like UTI, urinary tract infection, renal stones,
So
because history of plain abdomen was there.
It could be an infective cause.
Infective, right? Because history of fever was
fever,
there.
I stressed again, yes, importantly you write that maybe you need to talk about the common things common. This child had a fever for about 2 days or 4 days, 15 days ago, but it started off with fever.
Yes, sir.
So you think of UTI one.
First thing
I can keep UTI as one cause. But why UTI will cause so much of hematuria? It can occur.
It can be
and the child was excessively pale.
Yes.
That's very important.
Second
UTI will not cause so much of paleness. Yes, still okay. UTI is one cause. Kavya, you would like to say something?
Sir, hematuria with anemia. So we can and also renal is involved. Renal system is also involved. So sir, keeping these three in mind, sir, we can go towards TTP and
TTP.
HUS.
We never had any bleeding. I agree with you. One thing is there. TTP is not very commonly seen in children.
Okay, sir.
The prototype of TTP most commonly is the HUS.
HUS,
but
yes, sir.
On history and examination, it is very difficult to make a diagnosis of HUS.
Yes, sir.
Yes, but you low down, you can talk about it. Common things, by history, examination, you done the GP. What will you like to say? Shushma, you would like to say something?
Causes of intravascular hemolysis.
Yeah, the color was, you will see in the video, the color is not cola colored. So intravascular hemolysis will cause a coffee brown color, which was not there. It was reddish in color. So that means there is a bleeding or a hematuria is there. So if you have hematuria, blood pressure is normal, urinary output is normal, history of fever some days ago, UTI is one thing. I would still say you should not rule out the infective causes. So infective causes, common things always common. Don't forget malaria. Why are you forgetting malaria? Because I am doing some video, that does not mean I will only ask the uncommon things. No, my question of apprising you is that you have to talk of common things. So what is malaria? The other important thing I said in the history, leptospira. Because this child, I have specifically, that history was given to me. When you are playing in the pool, contaminated pool of water, rats also will be there, rat urine can also be there. So you had a child who leptospirosis should always be kept in one possibility should always be kept. But as she said, Kavya, you can't be away from the kidney. So what kidney can have? Divya can say, is supposing you have a marked hematuria, you have pallor. What possibilities or what kind of, it is a glomerulonephritis. So the glomerulonephritis in which there is a frank hematuria, you should always keep by history and examination as a rapidly progressive glomerulonephritis. So you should always say RPGN, I'll keep in mind. You see, the idea of presenting these cases are, you may come out with 10 causes or 10 differential diagnoses. That is by history and examination. But when you do the investigations, maybe some things will be weeded out. So one was RPGN. The other thing is even enteric fever can also lead on to problems of HUS. You said HUS straight away. So it could be infection first, you say. Now, why are you talking of HUS? Yes, we went on for the investigations. I'll read about the investigation. The investigations were carried out in this child, and interestingly, this child had hemoglobin only of the 4.7 gram %. TLC was 18,700. Platelet count was 95,000. So there was some thrombocytopenia. Though the history was only for 15 days, I still remember one of my senior residents was always insisting, rather almost all senior residents were insisting, these are the cases of, this is a case of a chronic renal failure. Sushma bhi bol rahi thi, Archana bhi bol rahi thi, everybody was talking, he said CKD, sir, it is CKD. Now the question is, CKD usually will not have so much hematuria. I have not gone to the investigations, but CKD usually will not have, the child may be having pallor, but so much hematuria will not be there. Okay. Then further we got the investigations done. What is the single most investigation? Vaishnavi, if you want to rule out, I must tell you, क्या कराना चाहोगे? What will you like to go for the investigation? If CKD है, whether it is an acute renal failure, what investigations you will like to go? Because everybody was insisting CKD. Okay, it is not being done in the, yes, we got it done in this child also. You are rightly saying, but this is one thing, he is right. But more importantly, before that is go for the ultrasound. Go for the ultrasonography. And we got the ultrasonography of this child done. And I'll tell you the findings. Bilateral increased echogenicity with partial loss of corticomedullary junction. Sizes are normal. Right side kidney was 9.6 into 3.4 centimeters. Left side of the kidney was 9.8 into 3.8 centimeters. That is for the age we verified. This child has got normal sized kidney. So if you have a normal sized kidney, the corticomedullary differentiation could be the part and parcel of the AKI. So if you have an AKI, you have blood in this. So it is unlikely. Yes, she rightly said, we went ahead and got the urinary osmolality also done. Before the urinary osmolality, you also must say urinary examination, because aajkal the trend is go for the very fancy investigation, but you people forget about the urinary microscopic examination. We got it done. The field was full of RBCs. Urinary proteins were 2+, and the casts were not there. Urinary osmolality was 1062. 1862. So it means the child, the kidneys are concentrating, kidneys are normal sized, so this is not CKD. So that is very clear. So CKD is out. Now when we were getting these done, we got the KFTs and as well as the LFTs. KFT of this child was with us for some time. It was ranging between blood urea ranging from 340, 350. So it was about 300, 340. That was the blood urea. Creat of this child was also ranging between 10 to 11. So in spite of all these, as I said earlier in the history, the child was conscious. There was no history of any, because uremic encephalopathy can also occur, but this child was normal. The sensorium was okay, but urea and creat was very high. Now at this stage, two important things, because I have Sushma Kumari, she has done MD pathology, so I'll ask her few important things, that this child is very pale. Any other pathological investigations which can to a large extent clinch the diagnosis?
Sir, peripheral smear.
Very good. So peripheral smear. What peripheral smear, what is going to tell us?
Sir, schistocytes, fragmented RBCs.
So you need to talk about
polychromatophils will be there.
Right. So you have to see the morphology of the RBCs. So I also was at loss on the first day that what could be the diagnosis. On the top of it, my senior residents always saying, sir, CKD. So it was going into my mind, CKD. So Sushma, the Archana is also here, CKD. So the question is, we got the two things done. Even I also did not notice or notice the platelet count on the first day, but you must see everything very common. It was 95,000. So it was, if it is 95,000, it is low. And as per the guidelines, if it is less than 150, at least it was low, less than 1 lakh. Now, I'll tell you the findings of the marked anisopycocytosis, predominantly macrocytes, macrovalocytes, teardrop cells, few microspherocytes, cystocytes, and fragmented RBCs noticed, with the peripheral smear also revealing that the platelets were reduced. This is one thing. Any other investigation which is very important, which you got it done afterwards, is the LDH. Now LDH is raised in such patients. LDH, there are so many causes of raised LDH. You must know before you go for the exam. It could be because of hemolysis. It could be because of malignancy. Because you see, it is intracellular. So when there is lysis of the cells, even in malignancy, LDH will be much raised. Any hematological cause which can lead on to raised LDH. Divya, would you like to say anything? Any hematological cause? It's a little difficult question, that is why I am asking you. That any, Archana can answer, any hematological cause, common cause, which causes raised LDH, you must know. I am very fond of it.
DIC.
Sorry?
DIC.
No, it is megaloblastic anemia. In megaloblastic or a macrocytic anemia, LDH is raised. Why? Because there is ineffective erythropoiesis. Because of ineffective erythropoiesis, there is lysis of the RBCs. And that raised RBCs also, lysis of the RBCs also called raised LDH. So you all must know the LDH. So we got the LDH also done after a day. And the LDH of this child was 3437 units per liter. Okay, LFTs of this child was mildly raised. SGOTP was 94.1, SGPT 25.1, serum bilirubin was 1.25. LDH I have told you, kidney functions I have told, ultrasound I have showed you. So keeping all things now in mind, this was basically a case of a acute kidney. It's a acute kidney failure. Now we kept the child for about 2 days or 3 days. Child was not improving. One thing I just kept in mind, as I said earlier also, we had kept this mind, kept leptospira in mind. Now I must say, I must thank, I had talked to Professor Manish Kumar. He is a professor of nephrology. He is doing nephrology at Chacha Nehru Bal Chikitsalaya. So this child was referred. I spoke to him. He says, sir, isko to dialysis ke liye lena padega, and dialysis facilities are not available in my hospital. So I referred this patient to CNBC. There the child was taken up, and at that time they also got the LDH done. They also got the peripheral smear done. And Manish told me that there are more than 2% cystocytes in the peripheral smear. And fragmented, they also said the same. And it was also running into 3000 the LDH levels. So that was a case of most likely a case of an HUS. Now my question is, we don't end here. HUS more commonly it's basically hemolytic uremic syndrome. Now hemolytic uremic syndrome is most commonly typical hemolytic uremic syndrome. And the other cause is the atypical hemolytic uremic syndrome. The more commonly it is the typical HUS. And typical HUS usually occurs secondary to the diarrhea. So I gave you the history. There was no history of any diarrhea. There was no history in the blood in the stools. So typical history was not there. It is mentioned that STEC, they call it STEC HUS. That is Shiga toxin, Escherichia coli, because that Shiga toxin causes sometimes this toxin. So this is one commonly there was no blood. So it is most likely, if at all it is there, it is an atypical HUS. In the atypical HUS, I must tell you here in this class that even I had seen only one case earlier. Atypical HUS, the most common cause is because there is a activation of the alternative pathway of the complement. But when there is an alternative pathway gets activated, the factor H antibody. In India, it is 50% of the time it is the factor H antibodies which are seen. So when I spoke to Dr. Manish said, I have sent the sample to AIIMS for anti-factor H antibodies because it has been found in more than 50% of the times. But then he also thought there was history of fever. So there is another group of HUS which is called common things common. Keep those things in mind. It is the infection-induced HUS. So they also sent the sample for, I forgot to mention about blood Vidal. Blood Vidal of this child was okay. There, they got it done. Blood Vidal was normal. Leptospira they sent, and they got the IgM serology positive for Leptospira. So I must confess here, we kept a possibility. Now they have got IgM serology positive for the Leptospira. So it could be even an infection-induced HUS. They put the patient on. What is the drug used for Leptospira? You can say doxycycline for HUS or for the Leptospira. Okay, I don't think so. Am I right or wrong? I don't know. He's preparing for the NEET. I don't know. Anybody? I think it's cephalosporins. It's third generation cephalosporins. But yes, Leptospira you can do ampicillin also. You can do doxycycline also. But this child was put on the third generation cephalosporins there. Now I'll give you the feedback what Professor Manish Kumar told me. This child was taken right away for the dialysis. 5 dialysis have already been done on this child. Following the dialysis, they have also done the plasma exchange. You do the dialysis in the morning, then followed by plasma exchange, because the antibodies are all there in the plasma, so you need to do a plasma exchange also. So that has been done. Now, since some of you are preparing for your exam, and this could be one of the question also, any monoclonal antibodies which can be used in HUS is eculizumab. So eculizumab is one question can come. So eculizumab, but then I tried to talk to him. So Dr. Manish told me, sir, it is available nowadays by the name of Solaris, but it is very costly. For this child, it will take about 20 to 25 lakhs of rupees. So, but he also said, I have a series of now HUS, atypical HUS. I don't know whether this is got an atypical HUS because of the antibodies or activation of the complement pathway, or it is because of Leptospira. Now I will tell you the status there, that the status is that this child has got, after these 5 or 6 HDs, Dr. Vikas is here, he is also from, he has worked in CNBC, he knows how good they work. So he always boasts of CNBC. So CNBC they done it, and now the urea has come down to 113, the creat has come down to 3.8. Only thing what happened there was, atypically, which was not here, that the child started having increased blood pressure. So what is important is, which I want to impress upon, the blood pressure may not be noticed in the initial stages. It was so high that the child threw a seizure also there. So they started this child on labetalol infusion. Now this child is on labetalol orally. Child has become better. Other important cause in HUS is cause of seizure. If anybody can tell me, I'll give a chocolate. Any cause of seizure? मैंने ही बताया था, लेकिन she clinches half the chocolate. It is not the hypertension. It is the thrombosis which occurs. So it is a microangiopathic. So because of the thrombosis, it can set in here and the child can come with seizure. So this child also had seizure there. So the report from the All India Institute of Medical Sciences has not yet come. If it is anti-factor H antibody, so Dr. Manish said that we will put this patient on immunosuppressants. Before that, we are waiting for we are doing the plasma exchange in HDs, and we have put the patient for the Leptospira. So I am trying to, I now wind it up saying it's not, I didn't want to show you the very important case of an HUS. Important thing is, nobody told me Leptospira. Nobody told me even simple things like malaria. मलेरिया किसने क्यों नहीं बोला? थ्रोम्बोसाइटोपेनिया होता है. थ्रोम्बोसाइटोपेनिया पर se can cause red colored urine. So why are you not saying? So take a good history, take a good examination, and then you can reach to a diagnosis. Thank you very much. Okay.